Good evening, it's Dr. Ballard. This is the abdominal exam lecture. Without further ado, let's get started. This is one of the most important body parts that you'll be examining that may be a little bit new for you. There are lots of disorders that you will be evaluating with the abdominal exam. It's part of a comprehensive physical examination, and we look for signs or symptoms of any type of abdominal disease process, as well as other system processes as well that may be referred to the abdomen as far as symptoms go. It involves core examination skills in a particular sequence. In the abdomen, the sequence is different than other body systems. This is something that you need to remember because you will see this on exams. So make sure that you put that in your memory bank, that the sequence of the abdominal exam is different. In the abdomen, we first inspect, just like we do other systems, but we auscultate before we do any other touching. So before we do percussion or palpation, we auscultate first, because the percussion and palpation may actually interfere with our auscultation and what we hear. So we need to do the auscultation first. So again, just make sure you remember that this sequence is a little bit different for the abdomen than other body systems, and you will need to remember this. So when you're looking at the abdomen, one of the things that you'll see on your exam sheet for your checkoff is that you want to look at the abdomen first. So don't forget to do this. You want to inspect the abdomen for skin characteristics. Look for venous patterns like petechiae, or you may look for spider veins or telangiectasia, things like that. You want to look for symmetry, whether there's asymmetry in the abdomen, whether there's surface motion, whether there's any swelling. You want to inspect the muscles as the patient raises their head to look for any problems such as masses, hernias, or separation of the muscles in the abdomen. So those are the first two things that you want to do when you're looking at or inspecting the abdomen. Then our next step is to auscultate using our stethoscope and the diaphragm. What we're going to listen for with the diaphragm is bowel sounds. The bowel sounds should be heard in all four quadrants, as you should be aware of as an RN. You probably do this on all patients in the hospital setting. But the other thing that you may not do is to auscultate using the bell of your stethoscope for bruits. And so what we're going to be listening for in the abdomen is bruits over the aorta, the abdominal aorta. We're also going to be listening over the renal arteries and the femoral arteries, or the iliac arteries. So making sure that you auscultate in those sites using the bell of your diaphragm. Our next step is to percuss, and percussing is a little difficult skill for students oftentimes. It's really challenging because we basically want to learn how to get a really good sound when we're percussing without killing our fingers. So you'll need to practice this technique, and we can practice this in the lab. But the main thing to remember when you're percussing is that it's in the wrist. You're basically going to try to snap your wrist, and what you're trying to do is using your middle finger, push that against the abdomen so that it's firmly down against the skin and the musculature of the abdomen. Then using the middle finger of your opposite hand, you're going to tap over the middle finger that's placed against the abdomen between the knuckle and the tip of your finger. You're going to touch, and you can hear that sound. Hopefully you can hear it on this recording. Now, if I don't have my finger pushed down really hard, the sound is much lighter. So I'm going to lightly touch the desk here, and you can hear the difference. Your fingernails have to be your fingernails have to be short in order to percuss well. So those of you who have your nails done, it's going to be really difficult to do a thorough pelvic exam or abdomen exam. So just one of the negatives of the trade, I guess, is that it's really hard to have really pretty long nails. But these are our tools. Our hands are our tools, and we need to keep them sharp and use them in the way that they're intended. So we want to percuss in all 4 quadrants or all 9 regions of the abdomen. We also want to percuss over the liver borders to estimate the span of the liver, the dullness of the spleen, and the gastric air bubble. Those you can see in your textbook and follow the instructions there. Then our next step is to lightly palpate, and we're going to palpate in all the quadrants, looking for muscular resistance, like if there's any tenderness and the patient is guarding, which is what we call muscular resistance, tenderness with the palpation, and we're palpating for any masses. That's light palpation. Deep palpation, we're going to look for bulges or masses around the umbilicus and the umbilical ring. We're going to palpate the liver border, look better just below the liver margin, the spleen, the right and left kidneys, and palpate
the aortic pulsation in midline, and for any other deeper masses that can be palpated.
Part of the abdomen exam is to percuss for VA tenderness, costovertebral angle tenderness over the kidneys. And you do this with the patient sitting.
As I stated before, the reason that exam form is in the sequence that it is to minimize the sitting up, lying down, standing up position changes of the patient. So some of the exam will be done with other parts of the systems, but that is part of the abdomen exam whenever you document it, just so you're aware that a lot of these things that you're doing may be done at different times, but when it comes down to actually documenting your examination, you need to put them in the right places. Okay, this is just a little review, anatomy and physiology. The abdomen houses multiple major organs. The peritoneum, which is a serous membrane, lines the cavity and forms a protective cover for many of these structures. The mesentery, which is a fan-shaped fold of the peritoneum, covers most of the small intestine and anchors it to the posterior abdomen wall. So these are things to keep in mind as we are examining the abdomen, kind of looking at the whole anatomy of in the abdomen. The alimentary tract is a 27-foot tube from the mouth to the anus. It includes the esophagus, the stomach, small and large intestine, and which includes the colon. The functions, obviously, ingest and digest food, absorb nutrients, electrolytes, and water, and excrete wastes. Peristalsis moves food along the tract under autonomic nervous system control. So just a little review here. Esophagus connects the pharynx to the stomach, and it descends through the mediastinal cavity, travels through the diaphragm, and enters the stomach at the cardiac orifice. The stomach is a flask-shaped organ that lies transversely across the abdomen. It is in the upper abdomen below the diaphragm. There's 3 sections of the stomach: the fundus, the body, and the pylorus. The stomach secretes hydrochloric acid and enzymes to help break down fats and proteins. Little absorption of nutrients takes place in the stomach. The small intestine connects the stomach and the large intestine. There are 3 sections that are coiled throughout the abdominal cavity. The duodenum, which is about approximately 12 inches. It has openings for bile and pancreatic ducts. The jejunum, which is about 8 feet long, and the ileum, which is 12 feet long. So the ileocecal valve between the ileum and the large intestine prevents backflow into the small intestine. The small intestine completes digestion through action of pancreatic enzymes, bile, and other enzymes, and the nutrients are absorbed through the mucosa. The surface area is increased in the small intestine by circular folds and villi. Then there's the large intestine, which connects the small intestine to the anus. There are 4 sections of the large intestine. The cecum, vermiform appendix extends from the base of the cecum. The ascending colon, transverse colon, and descending colon. Part of the descending colon is the sigmoid colon and the rectum and anal canal. The functions of the large intestine mainly are to absorb and reabsorb and reuse water for the body. It also functions to lubricate the contents from large quantities of alkaline mucus that neutralize acids formed by the intestinal bacteria. And putrefaction. Live bacteria decompose undigested food, unabsorbed amino acids, and cellular debris and dead bacteria. Another main organ is the liver. There are 4 lobes, and it's located in the right upper quadrant. The major function of the liver is to metabolize fats and carbohydrates, convert amino acids to glucose, synthesize fats from carbohydrates and proteins, store vitamins and iron, detoxify harmful substances such as drugs, alcohol, etc., produce antibodies and blood coagulants, which is something that I think a lot of times we forget about, and is synthesize bile and convert waste from fat to water soluble. The gallbladder is situated atop the liver, but kind of behind it. It's a pear-shaped sac-like organ, about 4 inches long, recessed behind the liver. Its function is to concentrate and store bile. The bile is made up of cholesterol, bile salts, and pigments. Bile is released into the cystic duct and the common bile duct and maintains the alkaline pH of the small intestine to permit emulsification of fats for absorption. So basically, its job is to break down fat and make it more easy for the body to digest and absorb. The pancreas, which is located behind and beneath the stomach, functions to produce digestive juices. It also has an endocrine function, which is the main one is to produce hormones that regulate the body's level of glucose, such as insulin and glucagon. The spleen, which is located in the left upper quadrant of the abdomen below the kidney. Now remember, the kidneys are retroperitoneal, meaning they're not in the front part of the abdomen, but in the back part of the abdomen, behind the peritoneum. So the spleen is located in the left upper quadrant, just below the kidney. Its function is to filter blood and white pulp or lymphoid tissue, and it produces lymphocytes and monocytes. The red pulp allows for storage and release of blood. Then we have the kidneys, ureter, and bladder. The kidneys, ureters, and bladder. The kidneys are located on either side, retroperitoneal, and connected to the bladder via the ureters. The ureters are like little tubes that come from the kidney to the bladder. Basically, they travel retroperitoneal, but actually come around to the front of the abdomen, kind of around the sides and down the front of the abdomen to the bladder. So keep that in mind when patients complain of flank pain or abdominal pain, because it can actually be kidney stone related, of stone traveling down the ureter. Functions of the kidney ureter bladders: to rid the body of water-soluble wastes, to produce renin, and part of the endocrine system, to produce renin and erythropoietin, and biologically active vitamin D. So patients who have chronic renal disease will oftentimes have problems with erythropoietin and vitamin D and anemia. It also functions to synthesize prostaglandins. Then there's the musculature and connective tissue in the abdomen, which form and protect the abdominal cavity. You have the large rectus abdominis muscle down the center of the abdomen, and the internal and external oblique musculature, linea alba, which contains the umbilicus, and then the inguinal ligament. The vasculature in the abdomen include the descending aorta. The branches branch into the iliac arteries, which there are two. They're formed from the division at about the umbilicus. There's the splenic artery and the renal arteries, as we are going to be listening for bruits of these arteries. In infants, we have pancreatic buds, liver, and gallbladder. They all begin to form during week 4 of gestation. The intestines already exist as a single tube. Meconium, an end product of fetal metabolism, is produced at about 17 weeks. By 36 to 38 weeks of gestation, the GI tract is capable of adapting to extrauterine life. Elasticity, musculature, and control mechanisms continue to develop, reaching adult level of function at about 2 to 3 years of age. The liver is very large at birth. You can actually palpate the liver in infants fairly well because it's very large. But remember, it's lower because it is so large. The metabolic and glycogen storage organ, and it remains the heaviest organ in the body in infants. The pancreatic islet cells, which produce insulin, are developed by 12 weeks of gestation and begin producing insulin. The spleen is active in blood formation during fetal development and the first year of life. Afterward, the spleen aids in the destruction of blood cells and functions as a lymphatic organ for immunological response. Nephrogenesis begins the second month of development. By 12 weeks, the kidneys are able to produce urine. There are new nephrons cease to be developed by the 36th week of gestation, and after birth the kidney increases in size because of enlargement of the existing nephrons and adjoining tubules. In pregnant women, the abdominal wall muscles stretch and lose tone. The organs are all displaced because of the increasing uterus, which affects their function. Oftentimes, heartburn results because of the alkaline reflux from the duodenal contents into the stomach. Gallstones may result from gallbladder changes that produce cholesterol crystals. Urinary stasis and urgency can occur because of pressure on the bladder. Constipation and flatus is more common, and hemorrhoids may result from increased venous pressure. Sounds like a lot of fun, right? In older adults, there are some functional abilities of the GI tract that are affected by age. The motility of the GI tract slows, which results in a lot of problems with constipation. Secretion and absorption may also decrease or slow down, and changes can impair digestive ability and result in food intolerances in older adults. Oftentimes they become lactose intolerant, and etc. The liver loses some of its ability to metabolize certain drugs, so we have to be careful about drugs and dosages in older adults. There may be an increase of biliary lipids resulting in formation of gallstones as people age, and the pancreas really has no significant changes, so it should remain fairly the same unless they have some sort of disease process, but it's not related to just aging. Alright, so let's talk about history. When we're doing a good history for the abdomen or an abdomen complaint, we want to do a general history of the present illness. We want to ask about any nausea or vomiting, any change in bowel habits. In other words, you want to ask the question so that patients will know what you mean. Don't just say, have there been any changes in your bowel habits? You may have to say it like, sometimes people report that they have regular bowel movements all the time. Have you had any changes to that? So, in other words, you were always normal and now you're having a lot of diarrhea, or you were always normal but now you're constipated all the time. So you kind of have to put it in a way that people can understand what that means. You want to ask about pain, weight gain or weight loss, any changes in appetites, ask about bloating, excessive gas, indigestion, heartburn, etc., any trouble swallowing, belching, any rectal bleeding. So bright red blood in the stool or black or tarry stools are important questions to ask about in our history in the abdomen or GI system. When we ask about abdominal pain, we want to remember our old carts. Remember onset, duration, the character of the pain, associated signs and symptoms, anything that's related to the abdominal pain. So any stool characteristics, like is it watery, is it green, is it brown, is it just loose, etc. What are characteristics of the urine? And then we want to ask about medications, including whether they're taking high doses of aspirin, whether they're taking a lot of NSAIDs or steroids, because these can have a GI effects. Indigestion, ask about character, relationship to amount, type, timing, food, etc., location, onset of symptoms, whether the symptoms are relieved by anything, including antacids, rest, activity, and what medicines they may be trying. Nausea, is it associated with vomiting or is it just nausea? Does anything in particular stimulate it, such as odors, activities, time of day, certain foods? When was the last menstrual period? Why would that be important with nausea? Well, the number one reason for nausea in females of childbearing age is going to be pregnancy. So we always want to make sure that we document the last menstrual period on our on anyone with this kind of complaint. And then we want to ask about medications. Vomiting, we'll ask about character, nature, quality, color, frequency, duration. Is it related to meals? Is there any diarrhea or constipation? And are they taking anything for it? Again, diarrhea. So all of these basically we will ask our old carts. Character, associated symptoms, any relation to food intake, stressors, whether they've been traveling. If they have, where have they been? Have they been camping? Have they been to, Colorado, drinking out of a mountain stream? Do they live in the country and have well water? Those are really important questions whenever someone comes in with nausea, vomiting, diarrhea type symptoms, because we could have bacterial infection, parasite infection, etc. And then we want to ask about whether they're taking medications, such are they self-medicating with laxatives, stool softeners, anti-diarrheals, etc. And constipation, a big problem for a lot of people. Ask about the character of the stool. I know it sounds awful that you have to get that down and dirty, as in other words, but we really want to ask, is it like little hard balls? Is it a formed stool? Is it hard? Is it soft? Is it runny? Is it, do you have liquid oozing out sometimes, because people can be impacted and still have watery diarrhea but really be constipated? What is the pattern? Do they have bowel movement, every third day? Do they go a week? Do they have to use a laxative to help them go? These are important questions. What's their diet like? How much water are they drinking? How much fiber are they getting, etc.? Are they on irons? Are they on diuretics? If they're having any incontinence, we want to ask about the character and the associated symptoms, and again, medicines and any related factors. For jaundice, we would ask about onset and duration. Important thing to ask about is the color of their stools. Is it kind of a white color that's associated oftentimes with jaundice and hepatitis? A clay-colored stool. Is the urine dark, much darker than usual? Are there any associated abdominal pain, any chills, any fever? Have they been exposed to hepatitis? Is there any lifestyle reasons that they might have hepatitis, such as recreational drugs, IV drug use, high-risk sexual activity? Have they traveled somewhere to another country where there could be unsafe water or other conditions? Is there an outbreak in the community of foodborne hepatitis, etc.? And then we would want to ask about high doses of acetaminophen and any other medicines such as anti-epileptics that can cause liver problems. The history of present illness with any kind of abdominal complaint should include inquiry about dysuria. If they're having difficulty with urination, is there character, location, suprapubic or distal urethra, any associated fever or other systemic signs of an illness, increased frequency of sexual intercourse, which can lead to urinary tract infections, and the amount of daily fluid intake. Ask about urinary frequency. Is there a change or a pattern, change in pattern or volume? Is there any associated with dysuria, other urinary characteristics like urgency, blood in the urine, incontinence, and nocturia is an important question to ask about, because that can be associated with benign prostatic hypertrophy, with diabetes, and many other metabolic conditions. Is there a change in the urinary stream? Do they have trouble getting started or stopping? Is there dribbling, etc.? Those can be associated with other conditions such as the prostate enlargement in men. And then we want to ask about medications such as diuretics. Any urinary incontinence should be evaluated, asking about the character of the urine, amount, frequency, any other associated symptoms that could indicate an infection, or whether it might be a stress incontinence or an urge incontinence. So we would want to ask about when it happens. Does it happen with sneezing, coughing, etc.? Does it happen just because they can't get to the bathroom in time? Or what is it associated with? And then again, medications. Hematuria, character, color, timing. Is it bright red blood? Is there just a little bit of blood on the paper? Associated symptoms, whether there's flank pain or CVA pain. Alternate possibilities, ingestion of foods containing red vegetable dyes can cause some red urinary pigmentation, so we might want to ask about those things. And laxative containing this particular chemical, phenolphthalein, can cause the urine to look red. The same thing happens whenever we give Urostat or certain other medicines to persons with a urinary tract infection. We want to caution them that this will turn their urine red and may look like they're bleeding. And then we would ask about other medicines, such as whether they're taking aspirin, NSAIDs, any anticoagulants, diuretics, or antibiotics. Past medical history is going to be important in our abdominal exam. Have they had a history of gastrointestinal disorders? The one thing you want to make sure you ask about is previous surgeries, because you go down this track of trying to evaluate somebody for gallbladder disease and then you find they've already had their gallbladder taken out. So it's important to know we don't need to go down that path because the gallbladder's gone. Okay, so make sure that we ask about those important things. Have they had hepatitis in the past? How much alcohol do they drink? Do they have any history of cirrhosis? Have they had any abdominal or urinary tract surgeries or injuries? How often do they have urinary tract infections? Is this a major problem for them, a recurring problem? Do they have any other major illnesses? Blood transfusions? What's their immunization status in terms of Hep A and B? And then any colorectal or related cancers. Let me get back here. So why would it be important for me to ask about their immunization status? Well, because we want to make sure as when we're doing our history that we're screening for anything that we may need to update patients for their wellness and health, prevention. Also, just to help us understand the possible problems or diagnoses, whether they have had these immunizations or not. Also, if someone's had their spleen removed, then they need to be immunized for these things because they have a decreased immune response without a spleen. We also want to ask about family history because many of these conditions are hereditary: colorectal cancer and familial colorectal cancer syndromes, polyposis, etc. Gallbladder disease tends to run in families. Kidney disease, malabsorption syndrome, Hirschsprung disease, etc., and then familial Mediterranean fever. So we want to make sure that we get a good family history, not just for the abdomen, but for every system. But for the abdomen, we would want to make sure that we ask about these particular things. Personal and social history is also extremely important. Ask about nutrition. What's their diet like? Are they on any vitamins and supplements? When was their last menstrual period, as we talked about before? How much alcohol do they intake? Don't just ask, do you drink alcohol? And they say yes socially, and you put down yes socially. What does that mean? You have to be specific. How much do you drink every day, and how much do you drink on the weekends? So we want to make sure that we're asking specific questions. What kind of alcohol, etc. Stressful life events, physical, psychological changes, any exposure to any infectious diseases, especially ask about travel history or trauma. Use of recreational or intravenous drugs is important to ask about, and tobacco use, whether it be smoking or oral tobacco. In infants, it's important to ask the mom about the gestational age and birth weight, passage of first meconium stool within the first 24 hours, whether they had jaundice as an infant. Ask about whether they're having vomiting, and if so, is it projectile-like? How frequent is it? Do they have colic? Is there any diarrhea? Are they having problems putting on weight, like failure to thrive, failure to gain weight? Are they losing weight? Are they having fatty looking stools, which is called steatorrhea, or that's a sign of malabsorption? Looking at apparent enlargement of the abdomen with or without pain, any trouble with having bowel movements, constipation, or diarrhea. In children, we want to ask about constipation. It's a very common condition in children. What are the toilet training methods? What have they tried for toilet training? What is the diet like? Is there any soiling? Are they having some incontinent issues? Is there any diarrhea? Are they having abdominal distension? Do they eat dirt, which is pica? the size, shape, and consistency of their stools, the time of their last stool, rectal bleeding, painful passage of stool. Are they having any abdominal pain? Do they have splinting of abdominal movement or resist movement, keeping their knees flexed? So especially if you have a child with abdominal pain, it's important to ask about whether they feel like eating. The number one sign of true appendicitis or peritoneal irritation is lack of appetite or not wanting to eat, and abdominal pain, along with abdominal pain. But if a kid comes in and say they have abdominal pain, but they're eating fine and they're not guarding, and then it's much less likely to be an appendicitis. So the diet and appetite is an important question to ask. Are there other psychosocial stressors? What's going on at home? Is there any problems at home? Divorce? Just recently moved? New school? Are they having problems at school? Are they having any kids at school that are bullying them? Important questions to ask, because oftentimes that's exhibited as abdominal pain in children. In pregnant women, we have common problems with urinary symptoms, frequency, urgency, burning, dysuria. Is there any odor or signs of infection along with the frequency? Are they having any abdominal pain? What's that like? Do they feel fetal movements? Are they having any contractions? Are they having any leakage of fluid or vaginal bleeding? And in older adults, we want to ask about urinary symptoms, especially nocturia and change in the stream for men, especially. Any incontinence in both men and women. Because a lot of older people think that incontinence is just a part of getting older, and they don't oftentimes tell about it because they just think it's normal. So we want to ask the question, because it isn't something that they should just have to live with. We want to ask about change in bowel patterns, again, because as people age, they have more risk for colon cancer and things of that nature. So ask about changes in their bowel patterns. We ask about constipation, diarrhea, fecal incontinence, blood in the stool, tarry stools, etc. Ask about dietary habits, whether they're eating enough fiber, whether they have noticed any food intolerances, whether there's been a change in their appetite, and what is their daily fluid intake. Okay, I'm going to stop right here and pick this back up on part 2 of the abdomen.